Good morning, and welcome to the webinar, Adaptations in Social Franchising, Promising Strategies for Scale, brought to you by the Sustaining Health Outcomes Through the Private Sector Plus project. I am Caroline Quijada, Deputy Director for the SHOPS Plus project and your moderator for this morning. Before we begin, let me direct your attention to the Q&A box on the right. Use that to ask a question or make a comment throughout the presentation. Please be sure to include your name, organization, and your location. Following the presentations, there will be time for discussion. Please send your comments and questions at any time. We are excited to report that there are over 200 people registered for this webinar from around the world. Let me extend a warm welcome to all of you. For our friends on Twitter, please follow the conversation using the hashtag #SochFranch. Before we begin, I'd like to just give a little background on SHOPS Plus. SHOPS Plus is USAID's flagship global project in private sector health. The purpose is to increase the use of priority health services through the strategic expansion of private sector approaches in the health system. Currently, SHOPS Plus is active in 9 countries. Why are we convening this webinar? I think first, we know that social franchising has successfully improved access, utilization, and quality of family planning and other high-impact health services. But current models face challenges of high costs and trade-offs between achieving scale and maintaining quality. Under SHOPS Plus, we are exploring, documenting, and analyzing a range of approaches that global franchisors such as Mary Stopes International and PSI are using to address operational challenges. So what will you learn today? The MSI and PSI social franchising adaptations shared in this webinar highlight operational approaches aimed at better leveraging health market opportunities, reducing programming costs, and achieving service delivery at scale. These adaptations are what we are calling low touch, meaning that franchisors find a more strategic way to resource key functions of the franchising support package. This allows franchisors to reduce the frequency or intensity of their interactions with franchisees, and franchisees themselves or other health system actors take on a more involved role. Lastly, we will share a draft of a conceptual framework or roadmap aimed at helping implementers identify opportunities for their own low-touch approaches. As we finalize the draft, your feedback on this conceptual framework will be appreciated. We have 3 presentations for you today. First, we'll hear from Brendan Hayes, Mary Stopes Channel Development Director for Social Franchising. Next, Anna Gerard, who's the Global Social Franchising Manager at PSI. And finally, our last presenter will be Sarah Thurston, who is a Technical Advisor for Mary Stopes. Now, I'd like to introduce our first speaker. Brendan Hayes is the Channel Director for Social Franchising at Mary Stopes International. He has more than 10 years of experience working in the developing world on reproductive health issues focused on private sector service delivery models. In his current role, he is the technical lead for MSI's Blue Star social franchise model, which has successfully networked more than 4,000 providers in 17 markets in Asia and Africa to deliver quality-assured reproductive health care services. Brendan holds an MSc from University College Dublin in Developmental Studies and a BA from St. Lawrence University in 2004. We are delighted to welcome him to this webinar. Brendan?
Thanks very much for the introduction, Caroline. As Caroline said, my name is Brendan Hayes. I'm the Channel Development Director for Social Franchising at MSI, and I'm going to talk to you today about how MSI is approaching the challenge of cost in our social franchising networks. I'm going to talk about 2 approaches. The first is looking at our existing networks and coming up with very simple strategies for figuring out how we better allocate resources within those networks to deliver on our health outcome objectives. In the case of Mary Stopes International, we are a family planning organization, and so our primary interest is to reduce unmet need for contraception and to expand access to family planning methods like long-acting reversible methods of contraception. And social franchising is one of the tools that we use to do that. The other model, or the other approach I will talk about are variations on the franchising approach. And so I'm going to look at two models that we're operating in our program in Pakistan, operated by Marie Stopes Society. And in that presentation, we'll look at the differences in those two approaches and some of the results that we've seen from that experiment that we've been running. Next slide. So the first point I wanted to make is that understanding your costs and understanding your cost structure is critical for improving your cost effectiveness. It sounds obvious, but I think it's often a missed component by programmers, by implementers, and there's often a lack of discussion and dialogue between finance departments in our country programs and our implementation teams to understand how costs get allocated within the channel, and how we can better use our financial data as important data for making program decisions. So this is just an example. Two of our larger social franchising networks in Africa. Our Ethiopian network has more than 550 providers and was established in 2009. And then our Blue Star Nigeria program has more than 300 providers and was started a bit later in 2012. One of the things you will note right away is that despite the fact that we're taking very similar approaches in Ethiopia and Nigeria, we have a very different cost structure. And we see that across our country programs. We end up with some similarities and some global insights that we can draw on, but there's a lot of market nuance to the cost structure. So, for example, depending on the distances between your franchisees in a market, your transportation costs may be a major cost driver, or it may be a less significant contributor to your overall cost profile. We also see that the age of the network and the development of the network is changes the cost structure pretty dramatically. So, for example, a social franchising network that is in an expansion phase is going to be a social franchise network that is investing a lot in that expansion, and often we see costs like training costs taking up a disproportionate share of the costs. For Marie Stopes International, one of the kind of keys to our success in this area has been having a standard chart of accounts across country programs and across channels that allows us to do these types of comparisons to better draw on our insights. Next slide. So what do we do with this information? So we are interested in MSI in improving the cost effectiveness of our social franchising channel, and for us, our kind of key corporate metric on cost effectiveness is cost per couple year of protection. So again, the first strategy that we're talking about is once you have a network, if you're in Nigeria, for example, and you've got 300 providers, and you're sitting down to make your 2017 work plan, how do we look at our current resources and how we're going to use those resources in the year ahead to maximize the number of women we can reach with family planning services. And so we've come up with a very, very simple framework, and this is a framework that's really designed to be implemented by a social franchising field officer. And the social franchising field officer is a team member who is managing a portfolio of 20 to 30 facilities within a larger network. And this framework is really just based on two key parameters. The first parameter is what is the potential of the provider, and that is the potential of that provider to increase the number of women they're reaching with modern contraception. Not necessarily current performance. What is the outlook? What is their potential? The second parameter is the behaviors of those providers. So we want them to reach lots of women, but we want them to reach lots of women in a specific way. We want them delivering a high-quality service. This is integral to our theory of market change, and so it's important that we have that quality embedded in the program. Now, how do you come up with these different metrics? Potential can be a very difficult measure or concept to capture quantitatively. We use a couple of different strategies. One, we look at the total footfall in a facility to figure out what is the viability of that business. We also like to use some qualitative assessment of the market potential by interviewing and talking with our field teams who are managing those franchisees. There's also an important motivation element to this. Again, very qualitative, but understanding the growth motivations of a provider. Many private providers are operating their clinics as a second career, perhaps after they've left a long career in the public service. Some providers are also running a healthcare business as a side enterprise while they do other things. If their full attention isn't on the healthcare business, then they're unlikely to grow that business. Next slide. So this is an example, recently conducted segmentation exercise in Madagascar, and this is how we would lay out the segmentation. You would have one axis, your left axis is provider potential. And so we would essentially divide all the providers into our high potential providers and our low potential providers. The left-right axis is provider behavior. And this is where we are bringing in measures like the scores on our clinical competency assessments and our quality assurance checklists, as well as other indications that the provider has the right set of behaviors, like their reporting rates for their service data. This allows us to categorize each provider in one of 4 boxes. Providers in the top right-hand box are our high potential, high behavior providers. These are providers that have a lot of scope for growth and are also exhibiting the right kind of behaviors. So the indicative investment for this type of provider is to intensify demand generation to try to maximize flow through in that facility and take advantage of that potential, to unlock that potential. By contrast, in the top left-hand corner, you have high potential facilities. They've got a lot of room to grow. They're motivated to grow, but they don't have the right types of behaviors. So their quality is probably not up to our MSI standard. And in that case, we would be intensifying supportive supervision. We would possibly be sitting down and coming up with a very specific work plan for each one of those providers to help reach their goals. Low potential, high behavior providers are interesting for the network. They tend to make up a large proportion of franchisees in the network. This is the bottom right-hand quadrant. In this case, we're not making any significant investments. We'd be keeping these providers in the network. And then our bottom left-hand quadrant, fortunately, are those providers who are unlikely to help us reach our health impact goals and are also not demonstrating the right kind of behaviors for franchise membership. And often we're looking at a defranchising approach to those providers. Next slide. So this is the strategy that we're taking forward presently in a number of countries. And really what we're trying to achieve here is to invest to maximize the strengths and address the weaknesses within the network to help our programs better prioritize their investment. Trying to implement an initiative across 3 or 4 or 500 facilities is very difficult. A tool like this can help a program to identify where they should be directing their investment, where they should be spending their time and energy. Going forward, we recognize that we need to be doing a better job screening providers before they come into the network. Defranchising, for example, has costs. We are also losing out on the investment we've made in providers, and neither of those 2 situations are something that we're looking for. So we want better providers coming into the network, understand what makes a good provider in the network, what helps us reach our health impact goals, and focus on those providers going forward. Next slide. Finally, I'm going to talk just very briefly about 2 different approaches we're taking in our program in Pakistan. This is Marie Stopes Society in Pakistan. Next slide. So first, just very briefly, talk about the service delivery approach that we take in Pakistan and many of our countries. So in this series of concentric circles in the middle, you'll see the MSI Open Door logo. That is the logo that we use for our wholly owned centers. That is the anchor of our service delivery platform in an MSI country program. Operates on a social enterprise model and is our benchmark for quality. Some limits on its ability to scale. And so outside of that, we take different approaches, including social franchising. And our social franchise network in Pakistan is branded Siraj, which is an Urdu word meaning sun. And that helps us achieve scale, helps us reach out into markets that may not be viable for a specialized SRH clinic. owned and operated by ourselves. So outside of the Siraj network, we have then explored a different type of partnership with private sector providers called the Peli-Karen network. And Peli-Karen is an Urdu word that means kind of first light. So this is a lower tier in our franchise approach, and these providers receive different levels of investment. Next slide. And these arrows will point out to you where each of those networks sit in our distribution strategy. So now I'm going to talk about the points of differences between these networks. And really, there's a core of similarities between these two approaches. We are training, we are providing that accreditation and third-party certification across both networks. We are making sure they've got access to quality contraceptives. We are quality monitoring the facilities they are undergoing. They're part of the MSI standard quality assurance process, and we are making referrals into this network. What's different is we have a much more intensive demand generation and demand-side support for the Siraj Social Franchise Network. This includes access to community-based mobilization. This includes contracting opportunities for family planning vouchers, a demand-side financing strategy, and it also includes some basic equipment support that isn't provided to the PK network. So what are the results that we've seen? Next slide. So what we've seen is that the Siraj network, and this is 550 network providers in Pakistan, is delivering a couple-year protection of a little over 2 pounds per CYP. By comparison, our PK network, this is more than 1,000 providers, a much larger network, is delivering a couple-year protection for just over half a pound. And so from this analysis, what this is showing us is that the Siraj network is essentially 4 times more expensive for each CYP delivered. However, the story doesn't entirely end there. I'm just going to move your attention over to the right-hand side of this chart, and you'll see the number of long-acting and reversible contraceptive clients that have been reached year to date. So more than 220,000 women. By comparison, the PK network, again much larger, has delivered those same services to less than 50,000 women. And so what we're seeing is that the Siraj providers are much more productive, in fact 8 times as productive when it comes to delivering large services than the PK provider network. And so this raises some interesting points. One is that quality and volume, again, both of these networks are actually the majority of clients, the majority of CYPs are coming from Love, so we have a somewhat similar method mix. And one of the concerns that we would have about these PK numbers is that volume is very closely related to provider competency and the ability to deliver quality service. So a provider who is very rarely doing an IUD insertion is a provider who's going to have a difficult time maintaining competency. So that is one challenge to this much larger, lower volume network, even if it is operating at a lower cost. The other point is these costs don't necessarily go away. So in Siraj, we are operating a demand-side financing mechanism. Those costs are included in this cost calculation. In the PK network, those clients are paying for that service out of pocket. So the cost hasn't gone away, but it's shifted from MSS's balance sheet to the client. And in that situation, we would have concerns that this is affecting both the volume of clients we can reach, and it's also potentially affecting our client profile. We may be reaching a much poorer client profile, for example, in our Siraj network. Lastly, scale matters quite a lot. Scale at MSI is not measured in number of outlets, but the number of clients served. And in a place like Pakistan, we are trying to reduce unmet need. We're trying to rapidly scale CPR. Given that family planning is such a good investment for health systems, we are trying to do that as quickly as possible. And clearly, even though the Siraj network is a more expensive model per unit of output, it may still be a good buy in this particular health system compared to a much lower volume approach like the PK network. Next slide. So just in conclusion, 2 points I'll leave you with are, one, measuring cost and cost effectiveness is essential if we want to get our heads around the cost of service provision, if we're going to resource service provision appropriately. This is an important element of sustainability, particularly as health systems and health markets shift towards domestic health financing. We need to understand the true cost of financing those services, so it's essential that we're measuring this. The link here on this slide is to some basic accounting principles for measuring and reporting cost effectiveness that have been agreed by a multi-agency group, Social Franchise Metrics Working Group, and you can take a look at that if you want to understand more about how these numbers were arrived at. However, the other important point to keep in mind is that cost effectiveness is not the only objective. We also have other objectives like quality, equity, and scale, and different interventions can create a different effect on each of these different priorities. And so while cost effectiveness is important, you also need to understand how changes in cost effectiveness affect some of these other parameters, like our ability to deliver a quality service and our ability to reach the poor. So thank you very much. I'll pass back to Caroline, and I think we'll have an opportunity at the end of the presentations for questions.
Thank you, Brendan, and thanks for your presentation and for reminding us about the trade-offs for sort of some of our low-touch strategies. Next, we're going to move to Anna Gerard of PSI, who's going to talk to us about the social franchising program at PSI. Bear with us while we make a switch to her slides. But let me introduce Anna. As PSI's global lead for social franchising, Anna provides strategic and technical assistance to over 20 country programs operating social franchises for healthcare delivery, supporting over 11,000 franchises. Anna moved to DC from the UK, where she led the development of Sightsavers, market-based approaches in eye health, innovating on refractive error delivery models to reach low-income consumers. Prior to the UK, Anna worked in several countries, including the Netherlands and Belgium, and she speaks French, Dutch, German, and Japanese. Wow. Anna has a law and European languages degree, an executive master's in international relations, and an MBA from the University of Liverpool. Anna will be discussing social franchising and PSI. Thank you very much for joining us this morning, Anna.
Thank you, Caroline. Thanks. Hello, everyone online. I'm Anna Gerard, PSI's Global Social Franchise Manager in Washington, D.C. Now, before I begin to go through three of our examples on the various forms that cost effectiveness can take at PSI, I just want to talk to you about our overall goal for health and social franchising and how we approach this through analyzing the market. So here at PSI, we want to harness the market for a strengthened health system while keeping the consumer at the heart of any solution. So at PSI, we use the market development lens and design service delivery solutions to address the question of who the market is failing and how. Firstly, who is the market failing? And our focus here is on the use and redefining what scale looks like in terms of need. So putting our marketing aspirations into a public health context, we start with the overall health need, and we consider this the potential market. And we consider the current users as the actual market. And our goal really is to grow the overall market until we meet the public health need. But what really differentiates us at PSI is how we use this analysis and the segmentation you see on the right of the slide to empower consumers. Because our target audience is not just a beneficiary of a health program, but really an empowered consumer who can make her own health choices. So when we use this lens, it's also about understanding consumer behavior and behavior change. And we've seen that it's not enough to make malaria diagnosis and treatment available in pharmacies. We also need parents to not stay at home when their child has a fever. We need them to show up at the pharmacy or the clinic, and then we've got to make sure that they have the product and service that they need. And we've also got to think beyond demand and supply for the products and services. Now, often market failures are at multiple levels. To achieve lasting impact at scale through social franchising, we need to think about the market ecosystem and how that needs to change for us to have a lasting impact at the provider level. PSI has been steadily moving into projects that are about market transformation and market development and not just marketing products and services. For instance, we've really had to up our focus on quality and labor capacity as we scaled up FP services. and a lot of the focus on social franchising is actually on those elements now. We're also seeing the need to figure out financing on the demand and supply side if we want to align our programs with universal health coverage. Social franchising will continue to play an important role in addressing market failures like, for example, quality of services, labour capacity and information. But we're also beginning to extend the focus of social franchising to address additional market failures based on systematic review. So the first example I want to share with you is our work specifically around quality and how we're innovating to bring down the costs of assuring quality standards are met in our 22 social franchises. So, quality assurance, which is a significant cost driver for an average fractional social franchise, not forgetting that we work through an integrated service approach, so we have a large packet of services to manage at the same time. So, how are we innovating at PSI to make our quality assurance processes more cost-effective? Well, this is Lena you see on the screen, and she's our quality assurance officer in one of our 22 countries. Her job is to make sure that our franchise clinics are meeting the global minimum quality standards, but she's got a really tough job to do because she's got to do this for about 80 clinics and pharmacies. So this process in the past has been managed on paper, of course, and as you can imagine, this is a pretty labor-intensive process. Every day she asks herself, okay, who am I visiting today? And she draws up a schedule and makes sure that appointments are confirmed. Which checklist am I using? Because each health area has its own checklist. And once she's visited the client, she returns with so much data on paper and spreadsheets that she's unsure how to help the provider to improve. So PSI designed HNQAS, which stands for Health Network Quality Improvement System, which is a tablet-based application that uploads results in real time. HNQAS has been designed to work with PSI's other quality assurance tools and resources to support quality improvement across all health areas, including family planning. So with 4 modules on planning, quality assessment, provider improvement, and performance monitoring, this electronic tablet-based application is principally focused on enabling quality assurance officers to support 4 areas. So the first area, effectively plan their support visits to franchisees, prioritizing where support is required and where it will have the most impact. Undertake assessments with comparable scoring and benchmarking mechanisms. Consistently and effectively provide feedback and coaching following these assessments, and monitor the performance of providers over time in order to ensure the return on their support efforts. HNQAS is fully functional without internet and operates off an Android application linked with the information management system DHS2. HNQAS enables programs to track the performance of individual providers and clinics in our social franchise networks, to track the results of their supported visits, and helps us prioritize supervisory visits and other quality assurance resources. So is this a cost-effective way of measuring and managing quality assurance? We believe it's much more effective than the paper-based system, and therefore we also believe that eventually it will be much more cost-effective than the old system. So the second example I'd like to share with you is our work on family planning in India. So for India to meet its SP 2020 targets, it would need to reach an additional 19.5 million users in UP and Bihar. The PSI in this project used a market development approach, which I talked about earlier, to understand the market for voluntary family planning in these 2 states before designing a solution. So using a market landscape analysis, we worked towards identifying why those millions of women who need family planning are not using any modern methods and why the market was actually failing them. So one of the barriers identified was that the private sector was unable to receive any state reimbursements for carrying out the FP services. So even though the mechanism was well established and it really should have been possible, in reality implementation was hindered by a manual and tedious accreditation system. And without accreditation and empanelment, no reimbursements were possible. So out-of-pocket costs remain needlessly high for consumers. what did we do here? We actually created a partnership with the State Innovations for Family Planning Agency, where we acted as an intermediary agency, which led to creating an easy-to-use web portal for accreditation, empanelment, and reimbursement. This system allows now for clear processes, guidelines, and rules for both the private sector and the government, and here are the results of that specific piece of work. Here we see the increase in the level of accreditation during the course of 1 year in the program. So starting at 12 facilities, it increased rapidly to 442 facilities. Now, the empanelment system means facilities are eligible for state reimbursements, which reduces the out-of-pocket payment that consumers are paying themselves. And again, we see a rapid increase in the number of empanelments. So as you can see, the contribution of the private sector went up by 7% in 1 year in these 2 states. Now, by doing the market analysis, we also identified that one of the other market barriers was the high-powered incentives for sterilisation, and there aren't any for other modern methods, which is leading women to choose this option, not perhaps for the reasons that they should. So, for example, women may undergo it because they felt they needed the money, or simply that these incentives have been shrinking the demand and therefore the market for other methods. So aside from offering a wide range of FP methods, which we could easily do through social franchising, a long-lasting solution for this requires a concerted engagement with multiple stakeholders to change the policy and to encourage the private sector to meet the increasing demand. Now, you may be asking yourself what this example has to do with cost effectiveness. Well, unlike other approaches, which would focus on increasing demand directly, by working in partnership as an intermediary agency, we were able to create real and lasting change at a much lower cost. Because this type of approach leverages structures and actors already in the health system, and it focuses on improving their functionality and fixing the kinks in the system, rather than creating and building new structures which don't necessarily have the buy-in needed to make them sustainable. The third example I want to talk about today is the integration of services and cost effectiveness. So we've been steadily increasing our range of services covered by the franchise, from family planning to including other areas, including maternal and child health, malaria, HIV, TB, and more recently NCDs, because of the evidence on the benefits of integration. We really see integration as important not only because it means less fragmentation of the service delivery for the consumer, but also because integrated services can be more cost-effective. So, for example, I've included a couple of studies here. The first example on the screen is one from India. This study evaluated the cost-effectiveness of implementing an integrated management of neonatal and childhood illness program in one district in India. The study found that around 75,000 illness episodes were averted and about 76,000 DALYs were achieved. And the incremental cost of integrating was $34.5 US and just over $1,000 per infant saved. And this study strongly recommended that this approach is scaled up as a major child survival strategy. The second example here on the screen is from Ethiopia. Despite significant improvements in access to modern family planning methods in Ethiopia, certain marginalized groups, including female sex workers, remain underserved. So integrating modern FP services into ongoing HIV prevention programs that reach specifically female sex workers was found to be an appropriate and cost-effective means to address this coverage gap. In general, there are many benefits to be achieved from integration if you get it right. The satisfaction levels can increase, the quality of care can be improved, and we can see an increase in the reach of care like in the Ethiopian study, as well as seeing a positive impact on DALYs, cost and equity. And the WHO suggests that integrated services are much more likely to be sustained in the long run than vertical programs and can improve health overall. So in summary, looking back at the three examples that I've talked you through, we can see that there are many forms that cost effectiveness can take. It can mean innovating with technology to create more efficient quality assurance mechanisms, or working effectively with other actors in the health system, or looking to integrate a broader range of services, which can achieve both a lower cost and a higher impact. So I'll hand back to Caroline now, and I look forward to taking your questions at the end.
Thank you, Anna, for sharing some of the adjustments that PSI is making in its programs to improve cost effectiveness, and in particular the three forms that you shared with us this morning. I want to remind those that are joining us via the webinar, one, if you are on Twitter, please join the conversation using the hashtag #SocialFranch. And also, please feel free to submit questions at any time. We will have a Q&A session following the presentations. Just please be sure to include your name, your organization, and the question in the Q&A panel, which you can see on the right side of your screen. Now I'd like to turn to our final presenter, who is Sarah Thurston, Technical Advisor for Mary Stopes. Sarah works with MSI's USAID team. Sarah has 12 years of experience managing sexual and reproductive health programs in Africa, Asia, and Latin America, and providing technical expertise for social franchising, health franchising, and public-private partnership initiatives. Sarah will be discussing the beginnings of a conceptual framework that can be used as a roadmap for low-touch social franchising approaches. So Sarah, welcome. And
thanks for the introduction, Caroline. As Caroline said, my name is Sarah Thurston, and I'm with MSI as a technical advisor. In this last presentation today, I'm going to talk a little bit about work under the SHOPS Plus project to synthesize and really scale up the learnings from the types of operational examples you heard from Brendan and Anna just now. For this, we've developed a conceptual framework that acts essentially as a roadmap for franchising implementers who are interested in replicating or innovating their own low-touch approaches. But before I dive into this, let me just take a second and recap how we're defining low-touch. What we mean is that the franchisor is finding a more strategic and often more cost-effective way to resource key functions of the franchising support package. In developing this conceptual framework, we took a look at a range of operational examples from the social franchising networks delivering SP, HIV, and some MCH services in different combinations. We reviewed published case studies, we looked through the social franchising compendiums, and did key informant interviews with global franchisors, MSI, PSI, IPPF, and DKT. And what we found through this was common themes in the sort of why and how of low-touch approaches, meaning why do franchisors use these types of strategies, and how can we identify new opportunities for them? So why do franchisors use low-touch approaches? Well, across the models we looked at, we saw sort of three main drivers, and those are improving programmatic cost effectiveness, that was a big one, but also building franchisee capacity, featured heavily, and supporting health system actors to take on the functions that they're meant to deliver. And often franchises are motivated by a combination of these goals. So where do opportunities for low-touch approaches lie? Well, broadly speaking, in the examples we identified, they work in one of two ways. They're either going to leverage franchisee capacity or capacity within the wider health market. But both of these work essentially in the same way, by allowing the franchisor to change the way it resources its involvement in one or more aspects of the franchising support package. From this review that we did, we developed a draft conceptual framework that acts as a roadmap to help franchising implementers identify their own opportunities. The framework sets out a three-step process that you see here. The first step in the process is clarifying objectives, so really being clear about what it is you want to achieve with your low-touch approach. Is it greater cost effectiveness? Is it capacity development of your franchisees? The second step is identifying appropriate opportunities for low-touch approaches, and this is the step that in a second I'm going to come back and talk more about. And then finally, the third step is ensuring that you have an evaluation framework in place that's going to measure whether you're achieving your aim. So for example, if you're looking to improve cost effectiveness, making sure you're measuring how the low-touch approach is going to affect your cost per CYP or your cost per DALY. So I'm going to talk a little bit more about this second step in the framework, which is identifying strategic opportunities for low-touch approaches. The first broad area in this is opportunities that leverage franchisee capacity. And these are the types of examples we heard from Brendan. To identify opportunities here, the franchisor really needs to know its providers, know what they're capable of, know what their strengths and their limitations are, know how their needs are different from one another, and this gives you the opportunity to segment them according to those needs and adjust the level and content of your supportive supervision, just like Brendan talked about in the Madagascar example. You also want to think about how their needs are going to change over time so that you can adjust your involvement as a franchisor accordingly. And finally, look for opportunities to invest in building your franchisees' capacity so that they can take on more themselves. The second main opportunity for low-touch approaches comes through leveraging capacity within the wider health market, and we're talking about both the government sector here and the wider private sector. And this market perspective is what Anna shared with us. To do this, you need to know your market, and conducting a health market assessment provides a really helpful jumping-off point. From there, franchisors can identify interventions that look to reduce market barriers. Likewise, they can look for opportunities to support other actors in the health system to deliver the functions they're supposed to be delivering. So let's take a second and take this out of the conceptual and look at a practical example. Let's look at the example of quality assurance. Quality assurance, as we all know, is a core component of most franchising programs. But as Anna just talked about, it's also among the most time-consuming and expensive, so it's a great target for a low-touch approach. We want to look at potential for low-touch quality assurance from two perspectives. First, from the franchisee capacity perspective, and then from the health market capacity perspective. On the left of this diagram, you see leveraging franchisee capacity. Here, franchisors can think about things like reducing the frequency or mechanisms of quality assurance for better performing franchisees. So perhaps you're talking about a quarterly rather than a monthly supportive supervision visit, or using mobile phones or other technology platforms like Anna described to replace some of the interactions usually done in person or help quality officers prioritize more strategically. There may also be opportunities for better performing franchisees to mentor those franchisees that need more support with their clinical quality. On the right-hand side, leveraging health market capacity can take several forms. For example, collaborating with district or state public health officials to undertake routine quality assurance tasks, adopting existing regulatory frameworks or tools as the franchise's QA methodology, and partnering with private professional associations such as midwives associations for quality support or to conduct QA visits even. We do know that these types of organizations vary considerably between countries in terms of their resources and capacity, but in the right context, these might offer a really good partnership opportunity. This process of exploring opportunities, first from the franchisee capacity side and then from the wider health market side, can be repeated for other components of the franchise package, so clinical training, demand generation, branding, marketing, business training, and other things that you as a franchisor entity might be offering your franchisees. But finally, and an important point, is none of this is to say that the franchisor should relinquish involvement in quality assurance or any other aspect of franchising. Instead, what this is really about is finding a different way to resource these functions so that the franchisor can fill a reduced but more strategic role. And we feel like thinking more strategically about this role for the franchisor is an important consideration for scaling up franchise networks and ultimately scaling their health impact. So we're working on refining and finalizing this conceptual framework to make it a useful operational tool to field implementers. And we'd like to have your feedback on the tool. We're looking for feedback sort of in two broad areas. First off, for franchising implementers, if your network uses a low-touch approach like the ones that we talked about today, or even different from the ones we've talked about today, we would love to hear from you. we're looking to collect more field examples to get a good picture of the range of approaches out there. And to the wider franchising community, we'd love to get your input on what you see as some of the main barriers, operational barriers in particular, to utilizing low-touch approaches. This will help us make sure as we continue to develop and finalize this framework that we're really speaking to addressing those barriers. So I invite you to share your thoughts through our Q&A time today and or by email. I have my email address here up on this last slide in the coming weeks so that we can incorporate your input into the next and final iteration of this conceptual framework. Thank you very much.
Thank you, Sarah, very much for your presentation. I think the presentation and the beginnings of this framework really bring together the work that Mary Stokes and TSI are doing in this area. And I do want to remind folks that while we have about 15 minutes for questions, the conversation certainly doesn't have to end at the end of our webinar. Both Sarah and Anna and Brendan are around and would be more than happy to engage in conversation, and particularly in helping to finalize and fine-tune the conceptual framework. So in these last 15 minutes, we definitely want to open it up for questions from all of you. We have just over 100 participants on the line, so we will do our best to get all of the questions that we're getting in answered. Just a reminder, if you have a question, please make sure to enter it into the Q&A box. Remember that panel, the chat box, is actually for you to communicate with the other attendees that are online, but the Q&A panel is where you should be submitting your question. Let us know where you're joining us from and your organization. I want to start with just a quick question to Anna, and it's about HMQIS, which I think actually is a really innovative tool to help bring sort of scale and cost effectiveness. I'm wondering, to what extent has that tool been scaled out throughout your franchises, and what are your plans for further rollout?
Great, thanks, Caroline. Yes, HMQS has been in development for the last couple of years. We started initially with the idea that we would use this for family planning and reproductive health, and then given the potential effectiveness of this tool, then other service areas kind of were put into the same tool. So now it covers, I think, almost 10 different service areas. So right now we've been piloting kind of last year, and we've got a full-scale pilot happening now in Kenya across our 300 franchises there. And once we get the results of this and fix any inevitable kinks in the system, because there's always some when you go live, then we'll be rolling it out across first stage, we think, by the first couple of quarters next year, into about a dozen of our franchises, and then beyond. And we hope within the next couple of years we'll kind of extend it to all of our 22 social franchises.
Great, that sounds great. And then a question for Brendan. I thought your data from your Pakistan program was really interesting, and I wondered why you looked at cost per CYP as opposed to cost per LARC delivered. It was a bit hard for me to sort of translate looking at how many LARCs were delivered and then the cost per CYP. Can you explain that a bit?
Sure. So partly this is because the data that I presented is routine monitoring data. So we do have a process for coming up with cost per service. We have a cost calculator that draws data out of our financial system and can produce a cost per service for each of the services that a service delivery channel is delivering. But the data that we presented today is the routine monitoring data. To allow comparison between channels and between country programs, we use a standard metric, which means that we're converting all family planning services using their CYP factor to essentially a common denominator that allows us to do that comparison. Essentially, I could have also presented CYPs on that chart. I think we probably would have seen a very similar distribution. Again, both of those networks, more than 70% of the CYPs being delivered in the PK model are LARC In the Siraj model, it's somewhat higher. It's north of 90%, but still a large proportion of the CYPs in both models are being delivered through LARC. But from a routine analysis standpoint, we use the CYP because it's easier for us to do those comparisons.
Okay, we're getting a follow-up question on that cost per CYP, which we just talked about, Brendan, and that is, are there any other advantages to the lighter touch PK model than cost effectiveness, and do you see potential for this to be scaled up or adapted in any other MSI country?
Well, in reference to Sarah's presentation and Anna's presentation, where they're talking about really understanding our market and making sure that we're tailoring our approach to what is needed to close those gaps and close those barriers, I think there are certainly opportunities. I think we don't always pursue I think to be honest, we pursued this approach in Pakistan because we had a resource limitation. We had an aspiration to be networking a large number of providers and to be running a large network, because at the time, the conventional wisdom was we want to reach lots of women, we need to be working with lots of providers. Now, it's interesting, the data doesn't necessarily support that, because we see that in any of our networks, we are often carrying a fairly significant proportion of providers that aren't very productive and aren't significantly contributing to the health impact goals. So I think, yeah, I think it's about being, I think there are certainly opportunities, but we want to be certainly pursuing it for the right reason. We want to be making sure that we are driving cost effectiveness. We want to be thinking about sustainability, and some of the points that Anna pointed out around kind of supporting the development of those functions in your health market for sustainability, there's certainly merit and value there. So yes, I do think that in other markets there's probably an application, but it would probably be very specific to the market circumstances.
Great. Anna, we're getting a question around technology and how technology is in fact being used to solve sort of scale and numbers problems across health areas and also in TB. Wondering if there are any plans, or have you any experience where you sort of handed over the technology management, in this case HNQIS, or any technology platform to a local entity, either public or private in country. Has PSI ever considered this? Are you thinking about this for the future?
So yeah, with HNQIS and another technology we've used currently and in the past, we really need to look at, firstly, we need to be sure that the technology is working effectively, and we're all about kind of having the studies to make sure that we know this for sure and we know that it's creating value in the system. So that's the first thing. And in terms of kind of handing over to local entities, we work through, we have a very decentralized system at PSI. We work through local entities in the field, and they are the ones managing HNQIS now. They work also with DHIS2, you may have seen that in my slides, and they're really the ones that take over the ownership of that technology and use it to create or to make those performance-based decisions in the field on a daily basis. So, yeah, to your point, I would say, yes, it's critical we all start looking, and we have been looking for a long time, on different types of technology and tools and methods. Just make sure it's cost effective and it's efficient, and ensuring that the local actor who takes it over has the capacity to do so, and the finances are supposed to do so.
So there's another question about one of your approaches, and that is looking at integration and integrated service package. Do you see better or different opportunities for cost-effective approaches or light-touch approaches with an integrated package as opposed to a package that's focused on family planning and reproductive health?
Yeah, so just talking about the integration of services then. So I mentioned in my slides, we take the consumer behavior stance. So we kind of look at everything through the lens of the consumer. And the example I gave is about the woman that goes to the clinic and she's looking for FP services, but she takes her child with her, and maybe her child has a fever or something else, and she wants treatment right there and then in that clinic. So we see the integration of services, and yes, we know it's more cost effective if done right, but we also know it makes sense in the eyes of the consumer. But in terms of, if you look at it through the lens of the health financing space and the kind of path to UHC, you know, we're all in the business of trying to reduce the out-of-pocket costs that consumers are paying for these services. So, you know, if we have a broader range of services available at the clinic that are franchised, these are more likely to be covered by basic health packages. And you know, once we help consumers to access national health insurance schemes that become available, then those out-of-pocket costs, which are pretty high at the moment, will go down.
Okay, great. I'm going to ask a question to both Anna and Brendan. I'm going to give you like a second to think about it, and then I'm going to ask Sarah a question because it's a little bit easier to answer. So the question really is about franchisor costs and recovery of costs. And there is a follow-up question around costs that franchises have to absorb when they integrate services that maybe were not part of the original franchise. Maybe it was a fractional franchise that was focused on family planning, and now we're integrating services. So how do you recover some of these costs, and how do you recover those costs without sort of skewing or sort of making an imbalance in the setup of that business? So think about that for a second. I'm going to turn to Sarah and ask Sarah, you have sort of made a call for additional examples, for experiences and with challenges. Is there a timeline? Is there sort of, you know, how would you like to receive some of that input? Is it by emails preferable?
Yeah, thanks, Caroline. Thanks for that second opportunity to follow up and with our call for further examples and our call for more experiences around what some of the challenges are operationally that our conceptual framework can speak to and help implementers overcome. Likely the easiest way to get feedback would be directly through email, and my email is on my slides, which are made available to all participants. So if there are any initial thoughts, please do shoot them my way. We'll also be releasing a draft by paper of this conceptual framework with a more formal call for feedback. And that would be sort of a second and perhaps more thorough way to give feedback if you have some.
Great. So we have a few minutes left, so I'm going to give Anna and Brendan an opportunity to answer the question around cost recovery, and I'm going to sneak an extra piece in there too, because someone asked about equity and how do light touch and cost-effective approaches impact equity. It's one of the pillars of social franchises. So I'm going to ask Brendan to go ahead and start. Give us your final thoughts, Brendan. I'm sneaking in 2 questions for the price of 1. And then we'll move on to Anna before we close.
Sure, and I'll try to address both the equity question, cost recovery question at the same time, and try to be brief. I think that this is a big challenge, particularly for our franchise model, which predominantly in most markets is focused on family planning services, preventative health services, obviously quite price sensitive. And so the margins available to providers are often also fairly thin. We don't have providers getting rich being franchisees focused on family planning services. We certainly see opportunities, particularly as health financing schemes, national insurance schemes start coming to the table, start covering more women. All of a sudden, buying power starts going up. We could be looking at different franchise models, and we are looking at some cost recovery franchise models in more mature markets where that's the case. In a place like Ethiopia, a place like Nigeria, not really our focus right now, really focused on health impact, and it's because even if we could recover costs from our franchisees, that is a cost that is passed on to the consumer. That's probably going to lower client volumes, as you saw in Pakistan in example, and probably going to limit our ability to rapidly scale up contraceptive prevalence. So I think this again gets back to what are we here trying to achieve, who are we trying to reach with our service package, and trying to understand those trade-offs. Sustainability is important, but I think really what we're talking about is the sustainability of financing rather than the sustainability of the service delivery platform. And that's a much longer discussion that I don't think we'll have time for right now. Thanks, Caroline.
Thank you, Brendan. Anna, any final thoughts?
Yeah, Brendan hit the nail on the head. It's a pretty challenging question. So quickly, I know we're running out of time, just a couple of points. If taking kind of the market development lens I talked about earlier, the India example, and in terms of fixing what needs fixing, and that's you know, really a good way of addressing it. The costs are much lower, and you can, you know, use the same staff then to move on to fix other things that need fixing. One example we have actually now is Tunza, so our social enterprise in East Africa, is moving into a social enterprise model. And, you know, the numbers say they'll be breaking even towards, you know, year 4 and 5. So we see, you know, in terms of the segmentation of franchises, you know, if you can segment correctly, then we can move some of those costs that are on the franchisor right now into different operational models. And then, I mean, the equity point is crucial that we keep looking at. That's one of the key metrics. But, you know, with the growth of new health financing schemes and national health insurance schemes, you know, we're really going to use our consumer behavior lens to make sure that those consumers who are the most vulnerable are included and have access to those services moving forward.
Great. Thank you so much, Anna, Brendan, and Sarah, for your participation and your presentations this morning. I'm sad to say we are, in fact, out of time. On behalf of the Shops Plus project, I'd like to thank all of you again for joining us this morning. We will be sending out a link to the recording of this webinar. If you have any questions or further thoughts from today's presentations, please don't hesitate to email us at info@shopsplusproject.org. Again, thank you, Anna, Brendan, and Sarah, and to all of you who joined us via webinar. Have a great day.